Welcome to today's session of Women's Health, and in today's session we're going to be looking at a very important topic, and we're going to be looking at hypertensive disorders in pregnancy. So to start with, we're going to classify hypertensive disorders in pregnancy to help us understand more and to help us make good clinical judgments. So hypertension in pregnancy is defined as a systolic blood pressure greater than 140 millimeters of mercury and a diastolic blood pressure greater than 90 millimeters of mercury on two occasions at least 4 hours apart. Chronic hypertension simply means hypertension that has been present before pregnancy or is diagnosed before 20 weeks of gestation. So it typically persists beyond 12 weeks postpartum. And what we need to know is that when you take a good history, this patient will tell you that I was actually taking BP medication even before I became pregnant. So we're going to look at gestational hypertension or pregnancy-induced hypertension, which is just the new onset hypertension developing uh, after 20 weeks gestation without proteinuria or any other signs of preeclampsia in a previously normotensive woman. Okay, so preeclampsia is just the new onset hypertension which happens after 20 weeks and is accompanied by proteinuria and other signs of maternal end organ dysfunction. So with that being said, we should also put in mind that preeclampsia can happen earlier in cases of molar pregnancy, that's before 20 weeks. So we need to take a good history and ask them if they had any history of having molar pregnancy in the previous pregnancy. So to make it simple, preeclampsia is just hypertension which happens after 20 weeks of gestation. Okay, so preeclampsia superimposed on chronic hypertension is just a situation whereby a woman was already taking BP medication or was being treated for hypertension even before the pregnancy, and she comes in and after 20 weeks she now develops preeclampsia, and she develops those signs of proteinuria and signs of maternal end organ dysfunction. So this now becomes preeclampsia superimposed on chronic hypertension. So there's a development of new onset proteinuria or other end organ dysfunction in a woman with pre-existing chronic hypertension. Okay, so with that being said, eclampsia is just the occurrence of generalized seizures in a woman with preeclampsia that cannot be attributed to other causes. Okay, so preeclampsia can also be further classified into non-severe or severe preeclampsia. So non-severe is also called mild preeclampsia. So with that being said, mild preeclampsia is just preeclampsia which has BPs greater than 140 systolic and less than 160, and diastolic greater than 90 and less than 110. On proteinuria, on the urinalysis, we're going to find 1 plus or 2 plus, and when you do a 24-hour collection, we're going to find about 300 grams of proteinuria. Okay, so when it comes to severe preeclampsia, we need to know that severe preeclampsia is just the systolic BP is greater than 160 millimeters of mercury or a diastolic blood pressure greater than 110 millimeters of mercury. So these readings should be confirmed on two occasions at least 4 hours apart to avoid a diagnosis based on a transient spike. Okay, so to also elaborate more on this, severe preeclampsia has to be accompanied by also features of end organ dysfunction such as neurological features such as severe headache which does not which can be frontal or occipital but does not respond to standard analgesia. So the patient can also come in with visual disturbances such as blurred vision, photopsia, flashing lights, or scotomata, which are just dark spots. So with that being said, the patient can also have hyperreflexia and clonus. So it's just it signifies that this patient can have upper motor neuron lesions. So they will have over responsive reflexes. Okay, so rather this is not a clinical sign, and it's not a standalone diagnostic requirement, and strongly suggests that there's an impending eclampsia. So we need to take action when we see such a presentation. So the other thing that the woman comes in with is hepatic liver dysfunction. So there's evidence of liver involvement that is defined by elevated liver enzymes such as the transaminases. So there's going to be raised alanine aminotransferase and aspartate aminotransferase at least twice the upper limit of the normal. So there's also going to be a severe right upper quadrant pain. So this severe right upper quadrant pain comes about due to the stretch of the glycerin capsule. So there's accumulation of blood under the glycerin capsule, which can also eventually lead to a rupture. So the patient can also come in with a gastric pain, and the patient will also come in with cases of liver dysfunction. So due to the case of glomerular endotheliosis. Okay, so the patient will come in with a defined serum concentration greater than 1.1 milligrams per deciliter, and also you will find that when you do a urinalysis, you will find that there's marked proteinuria. Okay, about 3 plus. Okay, so hematological complications, the most common hematological complication is that there's thrombocytopenia, which is just a platelet count less than 100,000 millimeters per cube. So this indicates a high risk of coagulation issues and internal bleeding. Okay, so the other thing that these patients come with is pulmonary edema. So there's presence of fluid in the lungs, and we need to do an X-ray, or we need to do a proper examination to find this fluid in the lungs. So you find this severe feature of pulmonary edema compromises the mother's ability to oxygenate and is considered as a medical emergency. Okay, so just to summarize all these findings, so we have to remember that when we do our full blood count, we'll find that the platelets are less than 100,000. When we do our renal function test, you find that the creatinine is less than or is greater than 1.1 grams per deciliter, and we also find that we have got liver transaminases about at least twice the upper twice at least more than the normal range. We need to check for cerebral features such as severe headache, visual disturbances, and convulsions, and also pulmonary edema. So, and the other thing we need to talk about is that these patients come in with proteinuria. So it's going to be 24-hour collection. We're going to find at least 300 milligrams. And when you do a analysis on a dipstick, we should find at least 3 plus for severe uh, preeclampsia. Okay, and when you do a urine protein creatinine ratio should be greater than 0.3. Okay, so with that being said, I would just like to tell you that we do not use proteinuria as a score to measure the severity of this condition, but we have to encompass it with other causes and other features of end organ dysfunction, such as the severe headache, epigastric pain, right upper quadrant pain, and also signs of end organ dysfunction, such as the persistent headaches, which are refractory to analgesia. So when it comes to the risk factors for preeclampsia, there's going to be previous history of preeclampsia has been seen to cause a high chance of a woman having it again. We're going to have a prime gravida, okay, a woman who's having a first pregnancy, and extremities of maternal age at least greater than 40 or greater than 35. Prolonged interpregnancy interval, at least a woman having pregnancy after a long period of time, after 10 years. Obesity, and also placenta related high villus load. So we're just talking about conditions such as a multiple pregnancy and also a molar pregnancy. We're also going to look at what can cause preeclampsia is pre-existing endothelial dysfunction such as chronic hypertension, chronic kidney disease, diabetes mellitus, and also antiphospholipid syndrome. Okay, so we should note to say that smoking can paradoxically lower the risk of preeclampsia, but the mechanism is quite unclear, but it's not a safe option for or a good preventive measure to prevent preeclampsia. So with that being said, we're going to look at the brief embryology which takes place before a woman reaches to all these stages of preeclampsia, and what happens. We're going to try to understand the incomplete trophoblastic evasion. Okay, so we're looking at the pathophysiology. Remember that The journey begins with fertilization, which occurs in the ampulla of the fallopian tube. So at day 1, the sperm and the ovum meet to form a single diploid cell, and at day 2, the zygote undergoes rapid mitotic changes, and by day 4, it becomes a solid ball of 16 to 32 cells called the morula, and the blastocysts are formed at day 6 to day 5 and day 6. As the morula enters the uterine cavity, the fluid uh, forms a cavity called the blastocyst. So at this stage, the blastocyst now differentiates into two things, okay? The embryoblast, which is the inner cell mass, and the trophoblast, which is the outer cell layer, which forms the placenta. So this is very important to know, because the embryoblasts will form the fetus, and the trophoblasts will form the placenta from the blastocyst. So now that we're going to focus more on the trophoblast, the outermost layer, and not the embryoblast, which is the one which is going to form the fetus. So around day 6 to day 7, the blastocyte begins implantation into the posterior wall of the uterus, and the trophoblast layer differentiates into two distinct layers. So there's a cytotrophoblast, which is the inner layer, and the syncytial trophoblast, which is the outermost layer. So at day 12, the blastocyte is completely embedded, and this is the foundation of maternal and fetal interface is established. So with that being said, I just wanted us to look at a brief embryology before we go into the pathophysiology. Now, what you need to understand is that we're trying to look into how the incomplete trophoblastic invasion happens. So in preeclampsia, the cytotrophoblast invasion is quite shallow, and it may penetrate the decidual portion of the spiral arteries, but fails to reach the deep myometrial segments in the second wave. So with that being said, that has consequences. So remember, let's put it easier, or let's first look at what happens on this theory of the two-wave evasion. Okay, I'll make this more simple, but I need to explain this. So the two-wave evasion is simply, it happens in two distinctive stages. So it's driven by the extravillous trophoblasts, okay, which are just specialized cells from the placenta that leave the fetal side to invade the mother's uterus. So in the first wave, about 6 to 10 weeks, the extravillous trophoblasts migrate into the decidual layer, which is the uterine layer, and they target the ends of the spiral artery. At this stage, they begin to break down the muscular layer and the elastic tissue of the vessel walls. Okay, so in the first wave, we should just put into mind that there's a shallow or this implantation which happens at the level of the decidual, and this very shallow. It just enters the spiral arteries very mildly. But when you go to the second wave, the invasion goes deeper and passing the decidual, and it then enters into the myometrial layer uh, of the arteries. Now, this is a make or break stage of a healthy pregnancy. Okay, remember, for this to work, the trophoblasts have to perform a remarkable trick called pseudovasculogenesis. Okay, so pseudovasculogenesis is just the trophoblasts change their surface proteins, the integrins, and the adhesion molecules to look like vascular endothelial cells of the mother. Okay, so to make you understand this is kind of think of it as let's look at this diagram, and let's think of it as the baby in this picture. The baby are the trophoblastic cells, okay? The construction workers are the trophoblastic fetal cells, and the mother there, you can see the blood vessel is being enlarged, and the babies are working with some peaks just to enlarge the vessel. Now the baby sends its fetal trophoblastic cells, okay, into the maternal circulation. But remember, the maternal circulation does not know these fetal trophoblastic cells yet. So the mother has got endothelial cells, okay. So the baby, the fetus trophoblastic cells have to go in there into the maternal circulation and they do that through the process of pseudovasculogenesis. Now, what do we mean by that? It means that the baby's fetal trophoblastic cells will go in and they'll wear a costume to mimic or to look like the endothelial cells so that the mother does not picture them or know them as foreigners. Okay, so when this happens, the babies are going to go in and wear a costume. The fetal trophoblastic cells are going to go in and wear a costume and mimic the endothelial cells. And what they're going to do when they go into the maternal circulation, they're going to make the vessel at least 10 times bigger, and they're also going to make the blood vessel, the maternal blood vessel, become low resistant and sluggish, in a sense that it's going to supply a high volume of nutrient blood. And they're also going to perform what we call denovation. Denovation meaning that the mother will lose its ability to constrict its own vessels, because the babies have taken charge, and the mother will lose its ability to constrict its own vessels. And then the mother also loses its fight or flight response when it comes to these vessels. So with that being said, hope we've understood the process of, or the process of pseudovasculogenesis. Okay, so if this does not happen, if the baby does not get what it wants, or if the baby does not negotiate well with the mother, what happens is that the mother ends up developing preeclampsia due to the incomplete trophoblastic evasion. Okay, so I hope this has made a lot of sense, and we're going to look at the actual pathophysiology now. Okay, so with that being said, the pathophysiology of preeclampsia happens due to incomplete endovascular trophoblastic evasion. So this happens due to in the second wave, there's poor implantation into the myometrial region due to uh, pseudovasculogenesis not happening, as we have explained earlier. That's how there's incomplete trophoblastic evasion. So the consequence leads to narrowing of the spiral arteries, which causes reduced uteroplacental perfusion, which then in turn causes placenta ischemia. So the placenta releases some inflammatory and anti-angiogenic mediators into the maternal circulation. So some of these include the soluble FM like tyrosine kinase 1, the vascular endothelial growth factor, the placental growth factor, and the inflammatory mediators. We have got tumor necrosis factor alpha, which is just a potent inflammatory cytokine which directly damages the endothelial cells. We also have interleukin 6, which acts or causes a systemic inflammation and activation of the coagulation system. We also have reactive oxygen species that cause oxidative stress to the maternal cell membranes. So all these factors cause or bring about endothelial damage, which in turn will cause a widespread multifactorial end organ dysfunction, meaning that it will target every part of the body. Okay, so it will start from the CNS all the way to the foot. Okay, so the endothelial damage happens almost in every organ. So there's vasospasm, so there's increased systemic vascular resistance. Okay, so that ends up causing hypertension, and there's capillary leakage, which causes generalized edema, and there's also pulmonary edema, and there's also platelet activation and consumption. So preeclampsia causes derangement of the clotting factors, and hence it ends up causing the consumption and also cause thrombocytopenia and thrombosis. So there's also thrombotic microangiopathy in the placenta, which causes fetal growth restriction, and there's risk of placenta abruption. Okay, so with that being said, what also happens is that this mother will have hepatic ischemia, which causes raised transaminases. So there's also periportal hemorrhage. So there's going to be stretch of the capsule. We have got the capsule which surrounds the liver, which is known as the Glisson's capsule. So when that Glisson's capsule is stretched and there's a blood accumulation under the Glisson's capsule, it's going to present with a boring type of pain in the right upper quadrant. and that's how a woman can come in complaining of right upper quadrant pain and also epigastric pain. In some cases, in some severe cases, the liver may cause the liver to rupture. Okay, so there's also what we call the kidneys are affected through the process of renal glomerular endotheliosis. So they're swollen endothelial fenestrations. They're going to impair the filtration, which is going to cause enlargement of the fenestrations, which is going to cause proteinuria, which we see when we do a analysis. You find the patient has got marked proteinuria, and there's going to be increased creatinine, and also there's going to be a hyperuricemia, which is just significant for we need to know it for the if to see if the kidneys are doing a proper renal clearance. So with that being said, when you go to the CNS, there's also going to be cerebral endothelial dysfunction and loss of autoregulation. Due to the theory of hyperperfusion, you will find that the vessels cannot constrict normally as they are supposed to, and that can end up causing endothelial capillary leakage in the cerebral vessels, and which can cause a vasogenic cerebral edema, which ends up causing release of excitatory neurotransmitters such as glutamate, and therefore it also causes activation of N-methyl D aspartate receptors. Okay, so which ends up causing a patient to have seizures. Okay, or even the patient can also present with a severe cerebrovascular accident. Okay, so with that being said, the renal changes once more are glomerular endotheliosis, which is just swelling of the glomerular capillaries, which effects which cause reduced fenestration surface. There's also increased serum creatinine, and there's also proteinuria from increased glomerular permeability, and there's also a risk of acute tubular necrosis if there is hypovolemia, and also it can also cause placental abruption. So with that being said, the endothelial damage can cause a multifactorial end organ dysfunction, as we've said, and it can also cause thrombotic complications and HELLP syndrome. So there's going to be a thrombotic sequelae, so platelet consumption, and also thrombocytopenia, which is just less than platelet count less than 100,000 millimeters cube, and there's also going to be placenta thrombosis. So there's going to be decreased maternal perfusion, which can cause fetal growth restriction, and placenta abruption is a risk. It becomes a risk because it is increased non-remodeled spiral arteries and hypertension, so it makes it more fragile. Okay, so there's the disseminated intravascular coagulation, which is possible in severe cases. So remember to say that when the spiral arteries are narrow, they become very fragile, and they're going to be transmitting blood at a high pressure, and they're going to cause placental hemorrhage. So there's going to be accumulation of blood beneath the placental detachment, which is then going to cause the placenta to start getting uprooted bit by bit, and there's going to be detachment. So this is how the presentation of placenta abruption comes in. Okay, so with that being said, the patient can also present with HELLP syndrome. So it's going to be hemolysis, okay, due to the platelet consumption and the arrangement of clotting factors, and also the macroangiopathic nature of this condition. And there's also going to be elevated liver enzymes due to the hepatic ischemia, and there's also going to be low platelets due to platelet consumption. Okay, it usually presents in the third trimester as well. So there's going to be hemolysis. So or when you do a peripheral smear, you're going to see cystocytes on the smear. There's also going to be raised lactate dehydrogenase or elevated bilirubin. Okay, so it's very important to know that we have prophylactic measures to prevent preeclampsia. So the timing is crucial because we need to initiate it before or during the spiral window. Okay, when a spiral artery remodeling is happening. So that's between 11 at least 11 to 14 weeks and 6 days. Okay, because we know that's when spiral artery remodeling begins to happen. Okay, so we need to give aspirin, and the mechanism of aspirin is simply it inhibits platelet COX, which reduces thromboxane A2 production and prothrombotic vasoconstrictor. Okay, so with that being said, we give a low dose of aspirin, which is about 75 to 80 milligrams, to prevent preeclampsia in a woman who is a high risk candidate for having preeclampsia. Okay, so with that being said, it's important to know that we need to give it at the right time, because if we give it at 20 weeks, it does not give us, or it does not suffice. It does not give us the results that we want, and it might not even prevent that preeclampsia. So regardless, we need to also have other preventive measures. We can give calcium. It may reduce preeclampsia risk only in women with documented low calcium intake or deficiency. Okay, so with that being said, we have also conducted some trials with vitamin C, vitamin E, and omega-3, but they have not shown any benefit. However, smoking has been associated with reduced preeclampsia risk, but is not advisable as a good preventive measure in pregnant women. So we need to do our investigations. When we do investigations, we need to order laboratory and also do our imaging. So when it comes to laboratory investigations, we need to do a full blood count and a peripheral smear to detect any thrombocytopenia, so platelet counts less than 100, and hemolysis. We're going to see schistocytes on the smear, and the key markers of these are key markers of HELLP syndrome. We're going to do a liver function test. We're going to check for elevated liver enzymes, which are going to rise at least 2 times than the normal, and they're going to indicate hepatic ischemia or subcapsular hematoma at the Gleason capsule. And we're going to check for lactate dehydrogenase, which is a significant marker for systemic hemolysis. Okay, so with that being said, we're also going to do a renal function test, and we're going to check for urea, electrolytes, and creatinine to screen for any acute kidney injury due to glomerular endotheliosis, and also elevated creatinine, which is greater than 1.1 milligrams per deciliter, which is a diagnostic feature of the severity. And we're also going to check for serum uric acid, okay, which is a classic biochemical marker for reduced clearance and increased oxidative stress in preeclampsia. So with these investigations being said, we can also do a coagulation profile just to check if the platelets are low, or if there's risk of if there's placental abruption being associated, to rule out disseminated intravascular coagulation. So with that being said, we can also do um, a bedside examination, such as urinalysis or 24-hour protein collection, to just to quantify the proteinuria. Okay, and we need to grade the proteinuria with 3 plus. We need to know that this is severe preeclampsia. Of course, we need to quantify it with other presentations of end organ damage. We also need to put this patient on a CTG, because they are at risk of having fetal hypoxia due to reduced uteroplacental insufficiency. Okay, we need to monitor for fetal distress. Okay, we need to we need to do our imaging, we need to do a CT scan, we need to do our chest x-ray to rule out pulmonary edema. We need to do our CT scan to rule out any focal neurological deficits, or if they're having persistent headaches which are refractory to standard analgesia. Okay, so with that being said, I hope we've understood the pathophysiology, the investigations, and how to classify preeclampsia so far. So with that being said, we're going to go to the management of mild preeclampsia. So I would just like to say that mild preeclampsia, we do expectant management, and severe preeclampsia is definitive management. We have to deliver the baby there and then, if the mother does not become stable after ensuing our BPs. So for mild preeclampsia, we're going to do expectant management. So we're going to do our general principles. We're going to admit this patient, and we're going to do our primary survey. We're going to do our airway and ensure the airway is patent. We're going to check for breathing. and make sure the saturations are greater than 94. And circulation, we're going to insert 2 large bore cannulas, and also maintain our BP, monitor our BP every 15 to 30 minutes. We're also going to do our urgent investigations as earlier stated, our full blood count, urea and creatinine, electrolytes, and also we're going to check for our AST and ALT, our liver function test, our enzymes, and lactate dehydrogenase, and also we're going to check for the coagulation profile, and also do a group and save and a cross match as well. So with that being said, we can also do a urinalysis, and when we do a urinalysis for mild preeclampsia, we'll find that this patient is asymptomatic, but they have proteinuria at least 1 plus and or 2 plus, and we're also going to send the patient for a protein creatinine ratio if it's available in our setting. We're also going to catheterize the patient to monitor the urine output, which should be greater than at least 30 mils per hour. So we're doing this just to know if this patient has got any oliguria or any existing acute kidney injury. Okay, so we're doing this just in case we put this patient on some medication such as magnesium sulfate. If it goes into a severe phase, are they going to have any implications? So for mild preeclampsia, we do not give magnesium sulfate prophylaxis. We only give it for severe preeclampsia. So we're going to put this patient on CTG. Okay, we're going to put the patient on CTG. We're going to make sure that we monitor the baseline fetal heart rate. At least it should be greater than 110 and less than 160. And we're also going to monitor the variability and also the decelerations. And why we're putting this patient on CTG, because they are at risk of fetal distress or fetal hypoxia due to the uteroplacental insufficiency. Okay, so they are at risk of having intrauterine growth restriction. Okay, so with that being said, we're going to ensure our antihypertensives just to make sure the BPs are stabilized. So we're going to make sure that we give nifedipine, which is a calcium channel blocker. We can start with 10 milligrams per oral, and we can also give methyldopa, which is a central acting alpha 2 agonist, which reduces sympathetic outflow. We're going to give at least 200 and 250 and 500 milligrams 2 to 3 times daily. We can also add atenolol to at least it's a beta alpha beta 1 blocker, though it's not the first line because it can cause risk of fetal growth restriction with long use. Okay, so we can give at least 20 to 25 milligrams daily. That's if the BPs are still refractory. We can also put the patients on corticosteroids such as dexamethasone, 6 milligrams IM every 12 hours, at least 4 doses, total 24 doses over 48 hours. And we put these patients on corticosteroids if they come in with a gestation less than 35 weeks. Okay, in some cases, we can use betamethasone at least 12 milligrams IM 24 hourly, at least 2 doses, but in most cases we use dexamethasone in our setting. Okay, so the mechanism of action of those corticosteroids is that they accelerate the type 2 pneumocyte maturation and increase surfactant production, and they reduce respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis, and also neonatal motility. And we have to make sure that the goal is that we ensure there's lung maturation which is taking place. Okay, so they just accelerate the type 2 pneumocytes maturation, and we give it to patients who come in with a gestational age less than 35. So the timing of delivery for these patients for mild preeclampsia, we have to do conservative management. So we admit them to the ward, we do BP monitoring and our labs weekly. We put them in bed rest in a left lateral position to lessen venous cava compression, and then we do daily clinical evaluation of any symptoms, headache, epigastric pain, visual disturbances, or oliguria. We check vitals at least 4 times a day. We monitor the state of edema and daily weight record. We monitor urine protein and monitor the urine output. We do daily urinalysis for protein check, and we do our baseline investigations. Okay, we also do our full blood count, platelet count, urea and electrolytes and liver function tests weekly, and we also do our ophthalmological investigations or examinations just to make sure there are no retinal detachments or papillary edema. Okay, so with that being said, we also do our fetal well-being assessment. We do a daily kick chart, and also we do our fetal heart rate monitoring daily using a fetoscope or peanut fetoscope. We do our CTG twice weekly. Okay, we do our obstetric ultrasound for growth every 2 weeks just to assess for the liquor volume. So our delivery plan, we aim to deliver at 37 completed weeks using the Bishop score, and a good Bishop score of greater than 7. We're going to induce with oxytocin, or we're going to rupture the membranes. With a poor Bishop score less than 7, we're going to use cervical ripening using prostaglandin E2 and misoprostol to prepare the cervix. If induction fails or there are any other obstetric indications such as fetal distress or breech presentation, we quickly take in the patient for cesarean section. So that ends our presentation on or that ends our management of mild preeclampsia, and we're going to go to severe management of severe preeclampsia. Okay, so with severe preeclampsia is quite intensive, and we're going to apply our same general principles. We're going to admit this patient to a high dependent unit, intensive care unit, or our special observation unit. Admit a patient to SOU or ICU, or we're going to do our airway, ensure the airway is patent. We're going to make sure that the patient is the breathing saturating above 94. Circulation, we're going to insert two large bore cannulas and collect blood for full blood count, urea and creatinine, electrolytes, liver function test, and also do a coagulation profile, and also do a group and save for these patients just to detect any HELLP syndrome or renal function failure or disseminated intravascular coagulation. We're going to monitor our BPs, okay, every 15 to 30 minutes, and then we're going to do a analysis, and it's going to be marked with about 3 plus proteinuria. We're going to send the protein and creatinine ratio if available. We're going to catheterize the patient and monitor urine output should be greater than 30 mL per hour to detect any renal failure. We are going to do uh, we are going to well, the reason why we're putting these patients on or catheterizing these patients is because we're going to administer magnesium sulfate prophylaxis in patients with severe preeclampsia, and we have to make sure that this patient has no signs of oliguria, because magnesium sulfate can cause toxicity if the patient has got a poor urine output. Okay, so with that being said, uh, we were going to also do our fetal monitoring, put the patient on CTG, because you know these patients are at risk of fetal hypoxia due to the uteroplacental insufficiency, which can cause intrauterine growth restriction, and also they're at risk of placenta abruption. We're going to monitor the baseline fetal heart rate to make sure that it's not tachycardic or bradycardic, and there's no fetal distress. We're going to check for the variability and also the decelerations on the CTG. Okay, so with severe preeclampsia, we need to make sure that remember the BPs, the diastolic is above 110. So we need to start our initial antihypertensive with our first line of drug of choice, which is labetalol, which is an alpha blocker, alpha 1 blocker, which causes vasodilatation, and the beta blocker, which causes reduced heart rate and cardiac output. So we're going to give this IV drug at 20 milligrams over 2 minutes, and if it's too high, we're going to keep doubling the dose 40 minutes after 40 milligrams after 10 minutes, and then 80 milligrams every 10 minutes to the maximum dose of 250 milligrams. Okay, until we achieve our intended results. So if you're in a if you're in a limited resource setting, we need to give a hydralazine. So hydralazine is just it's a direct arterial vasodilator. So we're going to start with 5 to 10 milligrams IV every 20 to 30 minutes, and the maximum dose of 20 milligrams. So the side effects of hydrazine is that it causes hypertension, which we do not want to happen because we do not want to cause placental hypoperfusion at a very fast rate. So this drug is not really the recommended first line unless things are just not on our side and we're not having the laboratory where we use hydralazine. So we can also give nifedipine, which is a calcium channel blocker, which relaxes the vascular smooth muscles, and our dose for that is 10 milligrams per oral, and we can increase the dose depending on our results of the BP. The other thing we need to give is methyldopa. At least it's a central acting, a central alpha 2 agonist, which reduces sympathetic outflow. So the dose is about 250 to 500 milligrams 2 to 3 times daily. So we give a maximum dose of 3 grams per day. Okay, we can also add atenolol and give a dose of 25 to 50 milligrams daily, though it's not the first line because it causes a risk of fetal growth restriction with long use. So we need to be very careful, when using this drug. So we also need to give these patients corticosteroids if they come at less than 35 weeks. So we need to give them dexamethasone at least 6 milligrams IM every 12 hourly, at least for four doses. So we have to give a total of 24. We have to give a total dose at least 24 milligrams over 48 hours. Okay, and we can also use betamethasone if we do not have that dexamethasone. We also give it 12 milligrams IM, at least two doses, 24 hourly apart. So with that being said, we need to start our magnesium sulfate prophylaxis. We need to do we're giving this prophylaxis just to prevent preeclampsia, and the mechanism of action of magnesium sulfate is it's an N-methyl D-aspartate N-methyl D-aspartate receptor blocker, and we give it to prevent these convulsions. So with that being said, we're going to give it using the Pritchard regimen, and we're going to, there are other regimens such as Zuspan, but in our setting we use the Pritchard regimen. Okay, and we give a loading dose. Also, we give a total dose of 14 grams, but the loading dose we start with 4 grams 4 grams, which is 20% IV over 5 to 10 minutes, and then 10 grams IM on each alternate buttock, at least 4 hourly apart. So 5 grams IM every 4 hours, okay, on each alternate buttock, so that to make a total of 14 grams. And we need to monitor for reflexes, so we need to check if our reflexes are present, okay, and also need to check our respiratory rate should be greater than 12 beats per minute. We need to check for our urine output should be greater than 20 mils per hour, and the antidote for magnesium sulfate toxicity is calcium gluconate. At least we give 1 gram or 10 milligrams of 10%, which is just the same as 1 gram. Okay, so with that being said, the definitive management of severe preeclampsia is termination of pregnancy, which is TOP or TOP. So regardless of the gestational age, we need to deliver the mother. As long as this mother has not stabilized, we need to cancel her for delivery of the baby because it's a high risk situation. So we need to deliver if she's greater than 37 weeks. We deliver within 24 hours or 24 to 24 hours of diagnosis. If she's at 34 to 36 weeks plus 6 days, we deliver within 24 hours of diagnosis. If she's at less than 34 weeks, we can try to do expectant management, waiting if the mother and baby are stable. But if the conditions of the maternal, if the mother and the fetus start deteriorating, we need to deliver immediately, regardless of the gestational age. Okay. So the mode of delivery for this woman with preeclampsia is we're going to induce labor. So induction of labor, we're going to use our Bishop score. If the Bishop score is unfavorable, it's less than 6, we're going to use prostaglandins into or misoprostol. If it's favorable, it's greater than 6 or 7, we're going to do artificial rupture of membranes, and we're going to use oxytocin. And remember that we have to put this patient on CTG throughout the entire labor, just to make sure there's no fetal distress or fetal hypoxia due to the risk due to the uteroplacental insufficiency. Okay, so if the induction fails, we quickly need to take this patient for Caesar, or if there are any obstetric indications such as breech presentation or any malpresentation or a previous C-section or a contracted pelvis, we need to take this patient for cesarean section. So our quick take-home points is that the management, you have to make a primary decision. You have to classify this preeclampsia, is it severe or mild? You have to make a decision, determine the gestational age, is it preterm or is it term? You have to time the delivery, is it severe preeclampsia? So you have to deliver within 24 hours if it's severe preeclampsia, regardless of the gestational age, after maternal stabilization. If it's any hypertensive disorder beyond 37 weeks, we admit and deliver, no need to wait for spontaneous labor. So if it's mild preeclampsia before 37 weeks, we just do conservative management until 37 completed weeks, unless it progresses to severe preeclampsia. So with that being said, this ends our session on preeclampsia. Hope or hypertensive disorders in pregnancy. Hope we've understood something, and subscribe to the channel, and stay blessed, and we'll continue posting more videos.